My name is Jordan Strom, and I am the Echo Lab Director at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and an Associate Professor of Medicine at Harvard Medical School. Well, that's the beauty of this, is that AI is actually integrated into our care already. And so there's this whole discussion about, is AI coming, or what AI will be coming? And I think we are all using some form of AI to some extent in our care already. So things like automated ejection fraction quantification, view recognition, automated global longitudinal stream are workflow enhancements that are already in our practice and are already speeding up the time and reproducibility in getting an adequate quality result. So this is really here already, and I think that will also help us regularize our practices with regards to some of these important parameters we obtain. It's always really thought of as a sort of a trade-off between accuracy and efficiency, and I want to say that hopefully AI will get us to the point where we are both accurate and confident. And there are many ways in which that may happen. Now, the best ways, I think, are really to help the clinician in what they're already doing as part of care. So things like triaging. We may not necessarily always have a sense of who may be the right patients to read, or the patients that are most urgent to read first. We can have things like stat studies, et cetera, that are ordered. But in the reality of it is those stats don't often have a very clear definition, and people can order a study as stat without it necessarily being clinically acute. But AI can sift through the vast data that's acquired through the healthcare system, as well as the order request, to essentially give us a rough sense of prioritization within the algorithm. And that can really help us focus on the things that are likely to make a meaningful difference in care immediately front. Understanding that there still may need to be some human screening in the background to ensure that things are not ultimately missed. The other areas in which AI could potentially really help would be earlier identification of certain diseases, and valvular disease comes to mind in part because it's something we see all the time on echocardiography and gets integrated into our reports. But to the extent that we may have blind spots, for example, we may be measuring an LVOT dimension wrong, or measuring an LV cavity wrong in the case of AR, and that makes a difference in terms of our decision making. I think that's where AI can really help to identify that the disease is present and that it's severe enough that there should be a signal to the person who's reading that this may be a more significant finding. And if the person who's interpreting it is able to take that into account along with the rest of the parameters that they acquire, then that ultimately could lead potentially to a better outcome for patients, although I think we do need to study this. 3 to 5 years is a very short time horizon. What I would say is there are lots of changes coming for all of our reporting softwares and our PACS vendors, et cetera. Basic things like automated measurements are already incorporated into a lot of the different algorithms that are out there, or reporting tools to be able to help flag patients and be able to communicate that to referring physicians, are things that are coming for our EHR, electronic health record vendors. Those kinds of things are going to make it easier to notify a referring provider of a critical finding, or send a letter to a primary care physician with the echo results, or even potentially sort of help improve both the quality, reproducibility, and consistency of the draft reports that the sonographers put together. At the end of the day, this is all going to require a lot of time and a lot of verification. So I think 3 to 5 years is a short time horizon. Of course, we know that a lot changes over the course of years, and there's a lot more coming down the pipeline. But in terms of anything that's going to radically change our care right now, within the next 3 to 5 years, I think we have to look at what's already out there in terms of both commercial devices, but also what has been approved and studied. And we have to consider how those fit within our given framework of care. So a couple examples I've given beforehand, but another example where disease recognition may help here is that there are now a number of algorithms that have been developed to identify certain diseases based on patterns that they see in the actual data itself. And so that could be potentially be helpful in generating an early signal that a disease may be present and allowing for appropriate and timely referrals. And I think we've already seen, now this is not with AI, but with electronic provider alerts, that there has been an improvement in both the timely referral for patients with aortic stenosis whose referrings receive those notifications, but also actually a change in ABR rates and mortality in that group. And so, I think that shows that there may be a significant promise for those types of tools. And I think that's going to change also the biases that we have in care, because we know that there are referral biases in that women and non-white individuals get referred less commonly in certain circumstances. And what we also know is that this kind of regular reporting system or integration into our reporting systems can help alleviate those biases and minimize them as we go forward. So I think there's a lot of potential for good things to happen here. I just think we need to understand the whole picture and make sure that we are not missing things or that there aren't adverse consequences that are inserted as a consequence of using these in more routine practice. So I think one of the really important things that might be coming down the pipeline is integration of multimodal techniques. We know that that doesn't exist in a void. A lot of our patients get EKGs, they get cardiac MRIs, other imaging testing. And I think more and more we're seeing AI applications being developed that integrate these multimodal pathways to be able to try to improve both the quality, but also the interpretability of the echo and the reproducibility for that matter. That has a lot of potential in expanding the use of echo as not just a single diagnostic tool that's available to the vast majority of the population, but also to give it capabilities that aren't otherwise inherent with the technology and the modality itself. And so that kind of integration of both multimodal data, but also including even clinical and outcomes data could be really tremendous in helping guide both future triage, but also the care for our patients and all of the patients who need care right away.